Coming up on Leaders in Healthcare, Dr. Jonathan Kaplan is a San Francisco-based plastic surgeon, entrepreneur, and the founder of Dr. Well, a provider-to-consumer model telehealth platform improving patients' access to treatments. In this episode, we'll learn about the ethics and economics surrounding the Ozempic craze, his approach to weight loss medications, and where this industry is heading for 2025.
What are your thoughts on more of the cosmetic, not obese patient being on the Ozempic?
We absolutely will prescribe to patients, even if their BMI doesn't meet that parameter. Weight loss can be healthy at any weight, possibly. Also, because there's so many other benefits to these medications that we're seeing now. I mean, there's some patients who are not overweight. They are not trying to lose weight, but they're taking the medication to help them curb smoking. And it's working for them. Or people are using it to curb their alcohol use. And it's working. Just go down the list with any symptom that any provider is treating. The underlying cause is probably obesity. So that's why it ends up going to make a lot more sense why all providers are offering weight loss meds. The compounding pharmacies in the U.S. were able to legally start producing duplicates of the active ingredients, semaglutide, tirzepatide, and the name brand drugs.
They wound up saving money on food. I mean, for you, what your background's obviously in plastic surgery. How did the pivot wind up going towards the weight loss side of things and like the digital therapeutics?
Right. Well, so I'm still a plastic surgeon, still operating. I have my own cosmetic office-based operating room in my practice here in San Francisco. But as you're going to find with a lot of providers across America, North America, that if you might be tempted to judge a book by its cover, like why is that provider offering weight loss drugs? So I'll tell you about why I got into it, and then I can quickly explain why this is going to actually be something that all healthcare providers in America are going to be doing. So specifically with plastic surgery, we noticed a few years ago, we had our patients who were coming in for consults for tummy tucks and other body contouring procedures. They were thinking of those body contouring procedures as weight loss procedures, but a tummy tuck isn't a weight loss procedure. It's to remove the excess skin after you're at a good weight. But so we noticed a lot of patients had a high BMI, high weight. They weren't good candidates for surgery. So rather than turning them away, our nurse and nurse practitioners suggested that we start a weight management program that they wanted to offer. And this was before the Ozempic craze and everything. And they wanted to offer, phentermine and coaching, things like that. And I was like, sure, go for it. And that was like 3 years ago. And then about 2 years ago, when the Ozempic craze really took off and they went on the FDA shortage list here in America, the compounding pharmacies in the U.S. were able to legally start producing duplicates of the active ingredients, semaglutide, tirzepatide, and the name brand drugs. And so then a few TikTok viral videos later, our weight management program blew up in our practice. And so still operating, but still doing a lot of weight management, helping patients get down to their goal weight in anticipation of surgery or just losing weight, which is great too. And what I was saying about other providers is that, this company I built, Dr. Well, which we can get into more in a second, we have other providers using our platform to help with weight and wellness programs. And so we have dermatologists using the platform. And so you're thinking, well, why is a dermatologist offering weight loss drugs? Well, because one of the most common causes of acne is obesity. And then you just go down the list with any symptom that any provider is treating, the underlying cause is probably obesity. So ear, nose, and throat doctor treating sleep apnea, instead of a CPAP machine, help them lose weight. If it's a orthopedic surgeon, instead of helping treating the osteoarthritis or a knee replacement, help them lose weight. And then you can get urologists are helping with erectile dysfunction by treating obesity, and OBGYNs are helping with infertility by treating obesity. So that's why it ends up going to make a lot more sense why all providers are offering weight loss meds.
Now, when it comes to the obesity epidemic and sort of the Ozempic craze, what are your thoughts on more of the cosmetic, not obese patient being on the Ozempic? Is that something you guys are dabbling with? Is that ethical?
Well, yes, happy to discuss that. So the first year that we were offering these medications, we knew that pancreatitis was a risk, but how much of it is it really a risk, on the street? How much is that a real thing? And so for the first year, we were very strict about BMI parameters, greater than 27 with obesity related conditions or greater than 30. And we were sticking to those BMI parameters. But after a year and treating around 1,000 patients, people were not getting those most serious side effects. Thank God. They were getting nausea and constipation, and I can prescribe Zofran with the best of them. And so we were definitely treating those mild side effects. But what we found over the course of that year, the side effects on average were mild, treatable, and time limited. They went away on their own eventually. But people were not getting pancreatitis. We even had 2 patients went to urgent care because they were having abdominal pain. We were like, oh my God, is this pancreatitis? Come to find out, it was purely 100% dehydration. And so that's one thing that we found that most people don't really seem to think about or talk about, is that because these medications suppress your appetite, you're eating less, but you're also drinking less. So I think the serious side effects are coming from dehydration. So after that year, realizing that people were not having the most serious side effects, now we absolutely will prescribe to patients, even if their BMI doesn't meet that parameter. Also keep in mind that we're talking about compounded versions of these medications, which insurance was never going to cover. And that's, I know things are different with the Canadian health system, but at least in the US, to have a chance of it getting covered by insurance, you would need to meet those BMI parameters. But even then, it's statistically unlikely in America that insurance is going to cover it, or they'll say they cover it, but the copay is like $1,000 and basically just the same amount as paying out of pocket for the name brand. So BMI became less of an issue. One, because we weren't dealing with insurance. And then the other thing was that we saw people were still doing fine, even if they did, when they were taking these medications. So we don't stick to that BMI parameter anymore. Now, if they're coming to us to lose weight before their wedding, yes, we'll prescribe them the medication. We're just not getting into that judgmental aspect of it. I mean, if somebody comes in and they have an eating disorder, like if they're overeating kind of a disorder, then yes, we'll prescribe the medication to them. But if they're anorexic and they have body dysmorphic disorder where they think they're not thin enough, no, we won't prescribe it in that case. And other medical issues, if they have a family history of medullary thyroid cancer, of course not. That's a black box warning with the FDA. But also if they've had pancreatitis specifically due to these medications, then we won't prescribe it. But if they've had gallstone pancreatitis, totally different etiology, then yes, we would prescribe it to them. But yeah, no, I know that is an ethical discussion, and I'm comfortable in saying that we prescribe these medications to people even if they don't meet those BMI criteria, as long as the rest of their medical history is optimized.
This podcast was brought to you by Cherry Health, the healthcare jobs network with over 35,000 jobs across Canada and the US. Physicians, nurses, pharmacists, and all other healthcare professionals can sign up for free. Start connecting, messaging with colleagues, or checking out job opportunities posted by thousands of employers across North America. With dozens of healthcare-specific job filters and search options, we make it easy to advance your career, find your dream job, or line up your next locum with thousands of new jobs posted every week. www.cherry.health to get connected today. It's an interesting topic of debate because we do a lot for just cosmetic outcomes, and actually I don't really know a whole lot about your plastic surgery side of your career. Is it more medical reconstructive? Is it more cosmetic?
Like a lot of plastic surgeons, it was reconstructive early on, but now it's 100% cosmetic. Eyelid lifts, neck lifts, breast augmentation, tummy tuck, liposuction, mommy makeovers, things like that.
Yeah. And so we didn't really cover this much in the green room here, but I'm also, one of my other many hats is the medical director for my wife's Medi Spa. Okay. She's like the nurse injectionist. And so the cosmetic side of the Ozempic usage, it's not something I have pulled the trigger on yet. And I don't know. I've just kind of been like, I haven't really convinced myself one way or the other. I've been on the fence. Like on the one side at the weight loss center, we use it a ton for the patients with the BMI criteria. And then on the other side, it's like all the different things that we have to offer to patients for the cosmetic outcomes and how happy they are and just how productive that can be for their confidence, their self-esteem, their mental health even. And then there's sort of just this vacancy on the weight loss side of things where the counseling around weight management, diet and lifestyle and exercise goes so far versus perhaps having that bit of a boost for somebody who's not in that obese category can still really benefit quite tremendously, I imagine.
Right. And also we do include coaching with it. And even when you mention it, cosmetic weight loss, I don't really think of it like that. Because, weight loss can be healthy at any weight possibly. But also because there's so many other benefits to these medications that we're seeing now. I mean, there's some patients who are not overweight. They are not trying to lose weight, but they're taking the medication to help them curb smoking. and it's working for them, or people are using it to curb their alcohol use and it's working. And there's data out there showing like that the alcohol use disorder, that these are very effective. So that's the other thing that's kind of hard to really tell patients. First off, it's human nature to say, well, if there's this, I'm exercising, I'm eating right, but I'm still not able to lose that 10 or 15 pounds I want to use. It's kind of hard for humans to say, oh, there's this really great new medication that will help me achieve my goals, but I'm not going to do it because it's only for obesity and type 2 diabetes. So it's really hard for human nature to avoid taking that opportunity. But the other thing is that it's really kind of we're recognizing how beneficial this is for so many other ailments, that even if patients are eating right and, but that, that's the food supply chain, maybe there's just too many high, carbs and highly refined carbs, and you can't really get away with it, and that's contributing to it. And that these medications can help them with that weight loss, but also with all those other issues that they may be experiencing. Then it's really hard as a healthcare provider to say, I'm not going to help you. And again, if it's all about the risk benefit ratio, and if there was an increased risk of pancreatitis, like a significantly increased risk of pancreatitis with these medications, then no, I wouldn't be prescribing it to those patients unless they met those BMI criteria and things like that. But that's just not the case.
How are you finding the tolerability? Like, from my experience seeing my patients, it doesn't seem like a fun medication to be on. Like, it's often unpleasant. After a while, usually they wind up getting used to things, but there's a big subset of the patients that are just like, this sucks. I don't know if I can keep on with it.
I guess there are, but it's also, we've offered other weight loss meds and other treatments and things like orlistat or phentermine, and people are much more miserable on those. Orlistat gives them terrible diarrhea. Phentermine makes them feel very anxious. And so I'm not denying that people have nausea or constipation with these medications, but in our patient population, that is resolving really quickly. And if they are having it, we don't just call them in a prescription for Zofran. We just mail them some Zofran. We mail them magnesium tablets. We coach them on treatments for constipation. Or if they're having sulfur burps, we'll just send them the ginger chews. So we do try to support them that way, and that's kind of included in their monthly subscription for the medication. But yes, certainly there are the potential for side effects. But again, I mean, based on our experience, they're on average, they're mild, treatable, and time limited. And we don't have patients saying that we don't have like a large percentage of patients saying they're miserable. It's funny though, because if you look at the studies that were submitted to the FDA for approval for Wegovy, the semaglutide, the weight loss version of Ozempic, the FDA studies that Novo Nordisk submitted showed that over their 1 year and 4 month study, that 44% of patients had nausea at one time or another. So 44% is pretty high. But then when you delve into that and you look at how many patients were actually driven to quit because of the nausea, it's only 1.8%. So it's actually really, really small number of patients that actually have to quit because of the side effects, nausea being the most common. That being said, I do think it's funny when I read the different the readouts, they'll say that, people had GI distress, that it was mild to moderate in nature. And they'll say the nausea and vomiting was mild to moderate in nature. And I understand how nausea can be mild, but there's never a definition where I think that vomiting is mild. Even the one time I'll have vomiting is the worst day of my life. It's awful. So I don't understand. So I think that's a little bit of a spin by the drug companies when they say it's mild to moderate, because I don't think you can have mild to moderate vomiting. I think it's just always severe, in my opinion. It's just the worst thing ever. But nausea, I can see how that's typically in our patients, it is mild and it's treatable.
Yeah, 100%. Like, if you're throwing up once here and there, that's still one way too many. And I guess then the other side effect being on the pocketbook, the bank account. But I actually had a patient kind of hilariously explain to me, this was probably a month ago, they wound up saving money on food overall. It had enough to offset the actual cost of the semaglutide, which I was like, that is a fascinating perspective. As well, the quitting drinking, you're really reducing that alcohol intake as an effect of it.
It's so true. We actually spend. Yeah, I'm sorry to interrupt. Yeah, we created a graphic in our practice based on our patients' feedback. We sent out a survey asking them, look at your Instacart, your Uber Eats, your grocery bill receipts, and look at those, add those receipts up from before you're on the meds to after you're on the meds. And they absolutely were saving money on food, and not necessarily saving as much as the cost of the medication each month, but it was certainly allowing them to allocate those resources that they weren't spending on food onto these meds. And again, if you talk about in the U.S., the name brand drugs are all over $1,000 a month if you pay out of pocket without insurance coverage. When we get it through the compounding pharmacy, we're able to offer it to patients from anywhere from $500 to $600 a month for semaglutide and tirzepatide, respectively. And I'm not saying $500 to $600 a month is cheap, but it's certainly less than over $1,000 a month. And we make it much easier for them to get because it's on shortage. They have to drive around sometimes to different states looking for a pharmacy who has it in stock. Whereas with us, because we're getting from the compounding pharmacy, we're able to ship it to the patient's door. And so there's some convenience in that, and it's still less expensive than the name brand. But I'm curious about in Canada, what are the prices there, and is compounding pharmacy an option in Canada?
It's about $400 a month if you're paying out of pocket, and then if you can get it covered, it varies depending on your plan. I honestly, I've heard a little bit about going the compounding pharmacy route. I don't think that's super popular here. I haven't really seen a lot of patients going that route to kind of get it through the side door.
Well, if the name brand is $400 there, then there's probably less of an incentive for the compounding pharmacies. There's not a whole lot of margin for them to go through all the effort of getting licensed to create the compounded version and then sell it. Because if they're only selling it for $350, people may just say, well, I'll just pay $400 for the name brand.
So is the compounding pharmacy route, is that a financial benefit, or was that a way to get around the shortage of just the actual pens of Ozempic TM themselves?
Right. No, so it's definitely a thing with the FDA that if there's any drug that is on shortage, it's not just weight loss drugs, but if there's any medication that's on shortage, the FDA, in their wisdom, still wants Americans to be able to get the medication they need. So they legally allow the compounding pharmacies to make a duplicate to get around and to get around that shortage, to fill that void that the big pharmaceutical companies can't fill themselves. And the thing is that I did the math on this, that if you look at the fact that a recent study, JAMA study, came out showing that 136 million Americans were candidates for these medications, whether it's because of the cardiac disease benefits, because it reduces major cardiac events, or because of the type 2 diabetes, which is the original indication for weight loss, that if you take all those three current indications, that's 136 million Americans that would meet that indication. And if you take all those Americans and they're all on this shot once a week, 4 times a month, 12 months out of the year, that would require 26 billion with a B, 26 billion injections a year to just keep up with that demand. And we're not talking about the future indications for fatty liver, chronic kidney disease, alcohol use disorder, maybe Alzheimer's, sleep apnea, osteoarthritis. So that's just the current demand. They need to make 26 billion. And so that's why the compounding pharmacies are going to be able to make these for a while in America, because they really just can't keep up with that kind of demand. And we're only talking about America. We're not even talking about the shortages they're having in Europe, or the shortages they're going to have in China or in India once they finally get approved there. So that's what the compounding pharmacy does, is they fill that void to address that shortage while it is occurring.
Who defines shortage?
Excellent question. Excellent question. So there's some debate about that right now, because the FDA recently took tirzepatide off the shortage list, the active ingredient in Mounjaro and Zepbound, but the reality is that it is still on shortage. So a lot of the evidence the FDA collects is from the pharmaceutical company saying that we're making enough to meet demand. We have all of these different dosages available, but you can have all the different dosages available but still be in shortage. Both things can be true at the same time. So obviously the big pharmaceutical companies saying they have enough of it is a conflict of interest. Of course they want it, because then you take it off the shortage list, compounding pharmacies can't compete with them anymore. But the FDA recently took off tirzepatide off the Outsourcing Facilities Association, which is the 503B pharmacies in America, which is part of the Food and Drug Cosmetic Act legal code, what defines a 503B compounding pharmacy. But anyway, the OFA sued, saying this is still on shortage. You can't make this unavailable for compounding pharmacies. Because the thing is that once you turn away millions of Americans from using the compounded version, they're going to go and scramble to try and get the name brand, which is going to just put it all on shortage again. Anyway, so it's partly defined by the pharmaceutical companies saying they have enough, but there's also the FDA takes samplings of different distributors to see what their current supply is. And that's really where they find that there is still genuinely a shortage. So for example, if I call one of the distributors and say, I have 100 patients that are on Ozempic, I need 100 pens. They'll say, oh, I can allocate 2 pens to you. So it's available, but not enough to meet demand. So there's a lot of partially good and partially bad data that goes into making that decision that the FDA determines whether things are on shortage or not. And then in this case, it's in the courts right now where they're hashing it out and showing that there really is still genuinely a shortage. They just can't meet the demand. I mean, it's almost laughable to suggest that they can, because even though 26 billion is the number I pull up from based on all of the potential people, even if you look at the actual people that are on the medications, they still can't meet that demand. It's still hard to find different dosages. It's not available at the pharmacy that you're used to going to. So they're still not meeting the demand.
It's wild that they let the company themselves define shortage, and it comes from that top up because they have no incentive to fib
Of
or
course.
fudge the data there. It's hilarious that it took Ozempic to actually get this into the courts and start having this looked at as well. Not all the other medications that are wonderful, but the semaglutide.
There are other factors that go into it, but certainly there's no denying that the pharmaceutical company is part of that. They provide some of that data to the FDA, and of course, yes, as you say, they have no incentive to say that there's still a shortage.
But yeah, 28 billion doses. We're going to need to start just putting it in the water. I guess, what do you think about oral semaglutide? Why is there not as much demand there versus
I thought you were going to ask about the way that RFK Jr. is talking about taking fluoride out of the water. We could put Ozempic in it. But as far as oral semaglutide, yeah, a lot of patients are really surprised. They're like, why are you talking to me about once a week injections when there's an oral pill? Why wouldn't I just take the oral pill? And I explained to them, I was like, this isn't anything new. It's the name brand is Rybelsus. It's on the market in the US, but it only comes in 7 and 14 milligram tablets. And it works for type 2 diabetes. But it just does. There's not enough bioavailability. Too much of it is destroyed in the stomach. So it just does not work for weight loss. It may have a place for maintenance once you get to your goal weight after using the weekly injection. But the thing that really has surprised me also, aside from the fact that, this oral semaglutide just doesn't work for weight loss, is that patients really are turned off by the idea of it being a daily pill. Like they were thinking, okay, it's Ozempic is a weekly injection. Oh, maybe the pill is a weekly pill. But it's not. And I would have always thought people would have rather taken a daily pill than a weekly injection. But people are all right with that idea of like, I only have to remember to do this once a week. And then the needles are really small and it is really well tolerated. And so I was shocked that people would be okay with a weekly injection and not so much a daily pill. They find that to be a hassle. Now, if Amgen's results come out with their drug Maritide, that we might have a monthly injection, which will be obviously huge as opposed to a weekly injection. So it's very exciting, this the pipeline that's out there, because I think a lot of people think that there's just Ozempic and Mounjaro and they created it and they work really well and they're done now. They're just going to stop there. Obviously, there's a lot more medications in the pipeline that are going to be great. And that's why this FDA shortage list is just going to be a revolving door, because even if Ozempic comes off the shortage list, Mounjaro, Zepbound are going to go back on or going to stay on. And then once Maritide comes out, although that may be too complex a molecule for the compounding pharmacies to make, because it's like a combination of a peptide with a monoclonal antibody. But I think it's going to be a revolving door as all these new latest and greatest drugs come out. They're going to quickly go on the shortage list.
Well, I'm glad we got you here. I feel like I'm talking through a portal to the future, because Canada, it seems almost like we kind of just wait for the FDA to like do the research and the studies and the approvals, and then we kind of just like replicate that and then check the box and say it's good up here. So what is coming next then? What are you the most excited for in that weight loss space?
Well, I think the one that's really probably on the verge of getting approved, probably in 2025 at the latest 2026, is a drug called retatrutide that Eli Lilly also makes. And that is a triple agonist where it affects the same receptors as a GLP-1, as GIP, which those two right there are what tirzepatide, Mounjaro, Zepbound do. But then it also is going to stimulate mimic glucagon. And so it's going to be that triple G agonist. And they're saying that that's going to provide, based on the data, that's providing bariatric surgery like weight loss. And that's called retatrutide. And the thing is, it's patented. So the formula is already out there. So there's actually pharmacies that are already making this as a research grade medication, which is not approved for human use. And that's not something that we offer within our platform to any of our providers. We're not connecting them to sketchy pharmacies like that. But retatrutide is already available as a research grade molecule, and humans can buy it, and they're not supposed to use it, but they, if they buy it, they can do whatever they want with it. And so people are taking retatrutide, and whatever the name brand drug is, whatever it's called, once Eli Lilly gets it approved by the FDA, that's going to come out in 2025, 2026. And that's going to be huge. Another opportunity. That's going to also be, I believe, as a weekly injection. And that's going to, we'll see. I mean, based on the data, it's providing greater than 25% weight loss. And it's very exciting what's coming down the road. But that's the future. And then this Amgen molecule is the future. The other one that's interesting is CagriSema. That's going to be the name brand, is a product that Novo Nordisk is working on. And what that does is that combines not only semaglutide, but also the molecule that stimulates amylin, which the idea there is it's going to stimulate or minimize lean body mass loss. So this is always a big thing people talk about, that, oh, these medications lead to lean body mass loss, bone and muscle. Well, any type of weight loss leads to lean body mass loss. So what they're talking about is adding the amylin, what's going to stimulate amylin receptors to help minimize lean body mass loss in addition to the weight loss. So the CagriSema is the name of that. It also stimulates calcitonin receptors, things like that. But so that's kind of the idea, is that's the other big future benefit, is that they're going to combine the ability to minimize lean body mass loss with the weight loss, which is huge. That's very exciting. So I would say retatrutide, maritide, and CagriSema are the big future players.
20% weight loss too. That is wild for a medication.
25% or greater.
25.
Like right now, Mounjaro Zepbound is already about 20%. But yeah, these newer drugs, at least 25%. Yeah, very exciting.
Now, how do you counsel patients around minimizing that lean body mass? Because that's a loss of the lean body mass.
Right. Excellent question. I think that's the other thing, is aside from people attributing the lean body mass loss to just these drugs, even though it's all type of weight loss, they also think of it as like this predetermined fate that they can't do anything about. And so, yeah, there is something you can do about it. Work out, eat high protein foods. I know you're eating less, but make sure that those meals count and have more protein in them. Protein supplemental shakes. But working out, like, even though diet and exercise has been this tried and true thing that we've always told patients to lose weight, and it's very frustrating because there's so many things at play that, whether it's their body set weight always eventually brings their weight back up. Diet and exercise still have their place. That's why we still coach patients and counsel them on that yes, maybe diet and exercise isn't alone going to get you down to your goal body weight and keep you there. Eating, maybe having better supply chain of foods and lower, less highly refined carbs, things like that. That certainly will help. But the benefit of diet and exercise will help minimize that lean body mass loss. So we're definitely always promoting that. I mean, I think the thing that we promote the most that people don't always think of is, one, the coaching on diet and exercise, working out, but also hydration, drinking fluids throughout the day, having a bottle of water. Again, if you're just trying to remember to drink, you probably won't because your appetite is suppressed. But if you have that bottle of water around, hydration and working out are going to help minimize most of the side effects associated with these medications.
What do you tell them when they ask, like, should I be doing resistance training versus cardio endurance training? One is going to contribute to my weight loss goal, but one might perhaps promote the retention of that lean body mass.
I think it all goes down to you have to do it all. You have to, it's moderation. You can't just do all of one thing or all of another. You have to moderate. You have to do all of it. So I'm a big believer in resistance training, cardio, jogging or Pilates or yoga, boxing, lifting weights, whatever it is that you possibly can do, whatever you can set aside time to do, you try to do it all, but ultimately you do whatever you can. But I don't necessarily promote one over the other. I think they both have their place for sure.
What are you doing? What's your personal fitness routine?
So yeah, I'm very happy with my routine. It's on Mondays, I do hot Pilates, which is like yoga and Pilates mixed together, but it's like in a hot room. So it's like calisthenics is the best way to describe it. It's calisthenics, burpees, and all these, abdominal exercises. But that's hot Pilates is on Monday. Tuesday and Thursday is kickboxing. which is boxing and kickboxing. And that's great. And it's like I go to a real gym with like a ring and everything, and I have a trainer. It's incredible. And that's Tuesday, Thursday. And then Wednesday and Friday is either yoga or hot Pilates as well. So I know that 5 out of the 7 days a week, I'm getting some really good exercise in. So I'm walking the walk, not just talking the talk.
You got to have the balance there. Yeah, it was a squats day for my wife and I this morning. And shout out to the good people at Good Life Fitness.
That's funny. Oh, and one other thing, it also helps that my wife cooks really good, healthy food. It's not processed food. And so that is so hard to do. And I know there's gurus out there say, oh, eating healthy isn't hard to do. It is hard to do. It's hard to do when there's so many easier meals to make, whether it's TV dinners or something that's got just full of preservatives and things. It's not easy to eat healthy if you incorporate it as part of your whole wellness routine or your whole family. I get it. I'm not minimizing the importance of it, but you can't keep talking down to people, telling them how easy it is to eat healthy. Luckily, I have a wife and we have a grocery store right nearby that's, I'm in San Francisco. They've got healthy foods and we're able to get access to healthy foods. It's a little more expensive. It's walking distance. My wife cooks it. It's great. But there's a lot of check boxes there to make that possible. So that's what I get aggravated about, all these talking heads talking about how you just like, it's easier to eat healthy. And like, tell that to the inner city kid that's like, all they have access to is like, the least expensive potato chips. Like I get it. It's like, it's easier to go that route.
Oh, no doubt. Yeah, you live in a food desert. There's no grocery store or anything reasonable around. I mean, just looking at the price of vegetables and fresh fruits these days, it's wild.
It's unbelievable. And that was a big turning point, not to get too political, but that was a big turning point for our presidential election, as people were like a roll of toilet paper or paper towels is so expensive. It's ridiculous. And people realized it was hitting their pocketbook. I think, the inflation was affecting them.
And so, Dr. Well, you guys are doing more than just the weight loss side of things. What are the other most popular demands and requests on the patient end? Is it hormones? Is it what else is on the up and up?
Yeah, no question. We started out, so I had this company was BuildMyBod, then became BuildMyHealth, and it was all about price transparency in healthcare, which has a lot more of a place in America than it does in Canada. Like, because people are getting these huge medical bills after the fact, and they never knew what things cost. So we started out as price transparency in healthcare. That evolved into, well, if you can check the pricing, then you can purchase. And that's how we got into the e-commerce. And then we got into subscriptions, and then those subscriptions were for Botox and things. But then those subscriptions evolved into weight loss meds. And so we're providing this platform that makes it very easy for providers to offer those weight loss meds to their patients. It's basically like taking that direct to consumer model, but putting it in the hands of a provider. So now, instead of the patient having a relationship with a website, they have a relationship with the provider. So that's how it evolved into weight loss meds. But now that we have this platform all set up for them, then we can offer all types of medications that are available from compounding pharmacies. So it's not just weight loss. We can get into things like minoxidil for hair restoration, oral minoxidil or finasteride. Those are all things that are now generic and available through compounding pharmacies for pennies on the dollar that our providers can offer through our platform to patients. But then also, as you mentioned, testosterone replacement therapy, estrogen replacement therapy, and also, things for not only hair restoration and hormone replacement, but, erectile dysfunction, sildenafil, tadalafil. So we're really allowing our providers to offer their patients anything that they can get through a compounding pharmacy for much lower cost than going to the traditional pharmacy. And maybe they still have even if it's, something that's generic from the pharmacy, the copay may still be more expensive than they can get through the provider from the compounding pharmacy. So we're the whole gamut, everything that I just mentioned, that we're helping our providers get access to.
How much has the demand for just that virtual and remote care changed down there? Like up here in Canada, it was like a switch flipped during COVID. Suddenly, the government that controls all the doctors' pay and the billing system that goes centrally, they were forced to kind of create these virtual care codes and adapt the system so that suddenly it became a whole lot more feasible for patients to actually get in touch with doctors through that virtual route. What did the evolution of that look like down in the States, where it's always been sort of private pay, third party?
Right. So telemedicine has definitely been a thing for, the last 20 years where they've tried to get telemedicine, more implemented, but patients were very resistant to it. It's kind of funny because it was so much more convenient than having to take time off of work and go into a doctor's office for a 5-minute visit. Or if you just needed a prescription, you still had to go in. So the different companies like Teladoc and things like that have always been trying to push telemedicine, but certainly overnight during the pandemic, it is really the go-to way of getting treatment now. And so that's the other thing that our platform is helping with, is making it very easy for consumers to get in touch with their provider. And our providers, use whatever method they want, whether it's a FaceTime call or Zoom or whatever they want to use to connect with their patients virtually. But patients are much more open to that idea. A majority of our weight loss patients are virtual, in that, and I have licenses in multiple states, or a lot of states. And so I can do these virtual visits all over the country. And then through our platform, we send the patient a link, either via text or email. They click on the link, and then they're presented with the page where they can sign up for the medication. They put in their credit card, they're charged, we're notified. That auto generates a prescription in the Dr. Well platform. And then we review that auto generated prescription. We click submit, and it's electronically routed to the compounding pharmacies that we're working with that can ship to that state, because the compounding pharmacies have to have different licenses in different states. So so it's electronically routed to the correct compounding pharmacy for that medication. So all of that process on the back end, that's virtual, that's electronic, that's automated, that makes it so much easier to provide this virtual care on the front end to the consumer. And the consumers love it. There's a lot of providers out there that say, oh, well, I want my patients to come in every week for their injection. I want them to come in every month to pick up their medication, because they're thinking, oh, that foot traffic to come in the office, they'll get other services. And I understand that business model, but the thing is, you're going to turn away a lot more patients than foot traffic you're going to get. You're going to turn away a lot more patients who are looking for that 100% virtual experience. And so if they don't feel like coming into your office to get those injections or to pick up their medication, they're going to come find a provider like me that they can do it entirely virtual with. And then, you ship the medication to them, and it's making it so much easier. It's increasing access. Now, people will say that's leading to overuse of the healthcare system. Well, you got to decide what you want. Do you want increased access, or you want them to have less access so there's less overuse of the healthcare system? Obviously, you'd like to find some moderation there, but I mean, we're increasing access, and our platform, because we're connecting patients to an actual provider's office, we're also providing that continuity of care that they're not getting from the direct consumer model. And which is certainly leading to the fragmentation of healthcare. We're trying to get it back to that doctor-patient relationship.
And then the critique of the virtual care model is often like, okay, this is an incomplete examination. You haven't been able to poke and prod at the patient. And this is sort of like the buzz from more of those traditional doctors that are doing the clinic model. No shade here. I've been like pretty much exclusively virtual.
No question.
Since the pandemic. I think the last person I actually saw in real life was like a mid-flight emergency. It was like, oh, a patient. I haven't actually touched somebody in a long time. But like, what do you say to those people that are still critical of like the adoption of technology into that care model?
Well, I mean, they'll phase out. That generation will phase out. And obviously, I'm not critical of the entire generation, because there's a lot of very forward-thinking people in those older generations. I mean, I think of my father, who was a general surgeon, that even though he was in the mid to latter part of his career, he picked up laparoscopic surgery. He saw that as the future. He went back and he learned that. So it's so not all older providers are as resistant to learning. A lot of them recognize where the future is going, and so they pick up on those things, and they recognize the benefits, and that there is a cohort of patients that are perfectly suited to virtual care. And while they might say, oh, but you might miss something. Well, when you're talking about population health, you're talking about the good of the overall population. You're not saying that you're going to eliminate every potential side effect or problem with every single patient. You can't do that. You're only going to mitigate or minimize it. So I think that you take the situation and you learn from it. So personally, as I mentioned earlier, we were very strict about BMI criteria, but we looked at our data and nobody was getting pancreatitis. So that's why we opened it up to patients who wanted the medication that didn't certainly meet the BMI criteria. Another way that we've taken the data and learned from it is that we were requiring everybody to get lab work before they started the medication. We wanted to know, and what we found is that, yeah, that was fine to get the lab work, but we didn't necessarily need to have the lab work before they started. So now We absolutely still get lab work on everybody, but we don't necessarily make them wait to get started until we have the lab results. Like, we make sure we get the lab results within about a month after they start. And the reason that is because I noticed after a year, all these people were getting lab work on or making them wait on lab work, that nothing in their lab work was precluding them from taking the medication. We still wanted the lab work. We still needed to know if they had an underlying condition they weren't aware of, that they needed to follow up with their primary care doctor about. But if they had some anemia, that wouldn't preclude them from taking the medication. They need to get worked up for anemia, though. If they had some abnormal figures in their liver or their kidney panels, well, these medications actually help reverse some of those things if it's, due to fatty liver or chronic kidney disease. But certainly if they weren't aware of it, they need to follow up with their provider. If their hemoglobin A1C was abnormally high, well, these medications, of course, originally indicated for type 2 diabetes, is the treatment for an abnormally high hemoglobin A1C. And with TSH, you're not going to diagnose somebody with medullary thyroid cancer because all of a sudden they get a high TSH. They know that from family history or a nodule or something. So again, this all goes back to my point that's why older doctors, we all have to continue to learn from the existing data that we have. And as that data evolves, our recommendations evolve. And so as we learned that the lab work wasn't changing whether we started them on the medication or not, we still got the lab work, but we wouldn't necessarily wait on the lab work for them to get started. And so that's what all providers need to continue to do. Like what you learned in med school doesn't always hold up 20 years later.
It's so true. Like just the demand from the patient side, or not even the demand, but like I see this all the time with starting them on like a mental health medication. It's like, okay, well, we can wait and bring you back. But like you've got that sort of window of opportunity there where the patient is receptive to getting on the treatment and they're like, okay, I can see the path forwards here. Like how many of those sort of artificial roadblocks do you want to put in the way between them and then hitting their goals?
Exactly right. No, it's so frustrating to the patient because because they don't understand all the fundamental knowledge you have as a healthcare provider. So they're not looking at all those different potential what ifs that you have in the back of your mind. They just like, I need some help. Are you going to help me or not? And if you don't give them the help in a way that you think you're going to be the most responsible about it, they're going to go to a different provider who's maybe not going to be as responsible.
Tell me a little bit more about Dr. Well then, in terms of like the model powering it. So we're going to see if RFK Jr. here in his crusade against the pharma companies and that like direct to consumer model winds up going the way of the dodo. But you guys are like very heavily entrenched in terms of the provider to consumer model.
Right. Yeah. So the direct consumer model, which the big ones here in America, it's just basically a direct consumer when it comes to healthcare. It's when the consumer can go online and sign up for medications pretty easily. And that's great. They're increasing access. They're making it easy for the consumer to interact, to get access. But the problem is that with that direct consumer model, I'm talking about companies like Roe or Roman, Hims, Hers, companies like that are big in the States, that the consumer can go on and fill out a questionnaire, and they call it an asynchronous consultation. And then some type of healthcare provider that's paid as an independent contractor reviews that questionnaire and says, okay, they're a candidate for hair loss or candidate for, weight loss meds, whatever. And then then that direct consumer website gets the medications sent to the patient. So that increases access to the consumer, but the problem is the patient's relationship is with a website, not with a real healthcare provider. And that's what we're doing at Dr. Well, is we're taking that technology that makes it easy for the consumer to get access, but we're putting that in the hands of the provider so that the consumer can sign up more easily and not have all those roadblocks that a typical provider would have, where, the provider might say you have to come in and then we, take your credit card, we hold the credit card number and we charge you each month for your subscription. Those are very manual processes. So we're taking all the automation and technology that might be associated with the direct consumer DTC model and applying it to the provider to consumer PTC model, which is a new space that we invented. We invented the terminology PTC, provider to consumer. And so the consumer gets access to the provider through either our provider finder website on drwell.com, or just the provider has their own practice and they have their own existing patients. They send out an e-blast to them, letting them know they're offering weight loss or NAD or other peptide injections. And So they meet with that patient either virtually or in person. And then, as I described earlier, instead of taking a credit card or having to charge it manually, the provider just uses our platform to send the patient a link. They sign up for that medication. They're automatically charged. We handle all the merchant processing. We do the subscription each month, the charges each month. And then each time a charge goes through, that auto generates a prescription so that the provider doesn't have to go find a compounding pharmacy, submit an application to the compounding pharmacy, give them their MPI number, get login credentials for that compounding pharmacy, learn how to use their online ordering portal. The provider doesn't have to do any of that. We've already completed the application, connected them to the compounding pharmacy, and all they have to do is go in the back end, review the auto-generated prescription, decide whether they want the medication sent to their office or sent to the patient. They click submit, and then we electronically route that to the compounding pharmacy, as I mentioned before. But you can see all the different potential manual steps in all of that the provider just can't scale up and see as many patients as they'd like doing it the old way. We're making it easier for them to automate that process. And then in the course of all that, we're getting better patient care for the patient because they have that continuity of care with the provider, and we're making that easier for the provider. But we're also in the process establishing relationships with all these compounding pharmacies and for electronic ordering. And anybody that's familiar with compounding pharmacies, they could be a big corporate compounding pharmacy, or they could be a mom and pop operation where you're still faxing orders to them, or you're emailing orders to them, or maybe they do actually have an API. So what we're doing is that we're meeting the compounding pharmacies on their terms, and we're finding a way to securely electronically submit those prescription orders to them, whether it's encrypted, whatever the encrypted channel is, whether it's an API or not. But we're forming this, basically we're becoming a clearinghouse or a hub to electronically place orders with compounding pharmacies across America. And you think of your typical EMR, they may already have electronic prescription submission ordering with like the traditional big box pharmacies like CVS, Rite Aid, Walgreens, places like that. But when it comes to compounding pharmacies, nobody really has that in place. And that's also another aspect of what we're doing here at Dr. Wells. We're becoming that centralized location where you can electronically submit orders to any compounding pharmacy across America. And that kind of network does not exist today, except in our hands.
It was fascinating how it works down there, just in terms of the back end. Like
Right.
I don't know, up here, we're particularly bad on the front end. Like when you think about the element of customer service in healthcare in Canada, it just does not exist. And so you guys are really like knocking down those barriers, the convenience factor, making it easy for the patient, while at the same time, like keeping those safety checks and that attachment with the provider in place. So you're not like completely eroding the fabric of healthcare and just giving everybody straight access to whatever they want, like it's picking it off a shelf. But then that back end of like, the stuff that we don't even think about here, like in a primary care setting, of like the billing and like how all of that goes through, really like connecting the logistics ends.
Correct. And it's been really exciting to, because when you start all this, you don't know exactly where you're going with it. You don't realize that these are all the different problems, but you stumble onto these different, disconnects in the system, and you realize, wow, there's an opportunity for us to provide a solution. And it's very satisfying. It's really fun to have all these epiphanies, these moments, these light bulb moments where you realize, oh, that's something we can solve for. Oh, that's something we can solve for. And to some extent, you're kind of surprised that we've gotten this far and nobody has come up with a solution for so many of these disconnects within the system. It's kind of amazing.
Every once in a while, there's like sort of an incremental change, but it really takes something special to get that stepwise, just 10x magnitude order improvement in a process.
Exactly right.
The compounding pharmacy side of things, is that the secret sauce driving it? Is just like making it accessible and affordable for the patients?
So I think that's something that people really don't get. And that's one of the silver linings of this Ozempic shortage. Obviously, a shortage of medication is always a problem. But if you want to look at the silver lining, it has allowed compounding pharmacies to come in and fill that void. And it's making compounding pharmacies a part of the conversation, because just like y'all may not be as familiar with compounding pharmacies up in Canada, there's a lot of Americans who have no idea what a compounding pharmacy is. And they may have even gotten medication for their pet before and didn't realize that was coming from a compounding pharmacy, similar to a compounding pharmacy that's used for humans. So that's one of the things that's really helped improve and increase the educational aspect of letting people know, informing people of what a compounding pharmacy does. But as they learn about compounding pharmacies, they're going to realize, wait, there's this other avenue where, yes, I have to pay out of pocket for it, but it's still significantly less expensive and easier for me to get these medications. And it may even be less expensive than the copay for the name brand drug or even the generic. So that's something that I think not just consumers, I should make it clear that providers also didn't quite understand what compounding pharmacies were. But there's, over 5,000 compounding pharmacies in the US. It's not like there's like 3 and just nobody knew about them. So that is really the secret sauce, is the compounding pharmacies are going to give more patients more access to less expensive medications that they knew existed before. And it's not just medications. It's also like topical creams, there's a lot of people who get like CBD creams, for back pain that people swear by, or these topical numbing creams that people are using in aesthetic practices. That compounding pharmacies produce all these things. And so it's educating both the public and the providers to this opportunity. And they're going to see that this provides them with better access and lower cost medications.
This is funny. I feel like I'm learning things as we go here. Because, typically you think of compounding pharmacy. It's like, okay, we're mixing up a magic cream for somebody's leg pain or whatever. We're going to have a little bit of ketamine in there and a little bit of whatever else. But this whole time I'm ordering my hyaluronidase from a compounding pharmacy, getting, more of those traditional injectable type medications. But that's just not what comes to mind when you think of it.
Correct. And the thing is, you have to also, it gives the opportunity to educate the public on, is that the compounding pharmacies aren't just mixing up their own ingredients that they've come up with in their backyard, like a still in your backyard making whiskey. But they're actually sourcing, at least the legitimate compounding pharmacies that we work with, that they get all their medications from FDA registered manufacturers. So there's a supply chain there that's either under the purview of the FDA or they're under the purview of the state board of pharmacy. Every state has its own board of pharmacy that's strict. I'm in California, which happens to be the most strict, which is great because that makes sure that all of our providers, all of our compounding pharmacies are at the highest level of accreditation. But that's the thing that people have to understand, is that these are all these ingredients coming from FDA registered manufacturers, and they're produced by pharmacies, sterilized and prepared by pharmacies that have a license either directly from the FDA or the State Board of Pharmacy. So it's nice to have a legit supply chain. You've got the certificates of analysis. You know where you're getting these things from, and you know they are what they say they are.
Very cool. Well, Dr. Jonathan Kaplan, thank you so much for taking the time today to share with us. Tell us more about the weight loss side of your practice as well as the virtual side. What's your website if people are looking to get in touch?
Yeah. So for providers out there that are looking to utilize the Dr. Well platform, they can head on over to drwell.com. That's drwell.com, just like it sounds. And then they can even email me at Dr. Kaplan, DrKaplan, Dr. Kaplan at drwell.com. Very easy to get in touch.
Thank you so much.
Thanks for having me.